Thank you so much, and it's great to be in the room with all of you at such a busy time. And thank you also to Steve Brine. I think it's always reassuring to see someone who's exhaustingly committed to his role in Parliament, and I think the work of the Select Committee is incredibly important in giving the time and energy to look at the evidence about how our health and social care system is bearing up under extreme pressure. So thank you, Steve. What I'm going to do, I don't have loads of time, so I may have to skip through a few of my slides, but what I'm going to try and do is say, obviously, a bit about the current pressures, to talk about our negotiations and an update on that, to talk about preparing for the next contractual framework, and talking about the vision for community pharmacy and how we can use it to influence. And then I'm not taking questions now, I think, because we'll do a Q&A later, a panel session later. So, first of all, of course, you all know, as my whole committee are business owners and working in community pharmacy, you all know as well as we do what terrible pressures we're facing at the moment. And this has been really the result of a determined strategy to reduce the funding for community pharmacy. So in real terms, cuts of 30% over the last 7 years. So that's really started to bite, and as we get to the end of the 5-year contractual framework, you can see that impact. And that funding gap of £1.2 billion we've calculated where we should be if we just kept up with inflation. And even if we'd kept up with what the NHS got, we'd have 520 million. So there's a huge gap. There's a growing prescribing volume and inexorably rising demand from that, and demand from patients who learnt through the pandemic where to go to get an open door and to get the health advice and support that they need. And also, of course, dispensing at a loss and the real problems we're facing with the pricing of medicines, and I'll talk a bit more about that. Workforce shortages and rising costs, inflationary pressures that have really bit hard into your operating capital. And consolidation, this has been shown, the impact. If you really, really squeeze to death a sector, then you're going to get closures and consolidation. That's most notably been seen in Lloyd's, selling on their business, getting out of the business, Boots, consolidations, which now people are starting to wake up and notice. But of course, independents hanging on in there, but facing administration, cash flow problems, and all the rest in terms of facing potential closures. So this, of course, is impacting on communities and patients to the extent that even the government, even NHS England and the ICSs, PCNs and GPs are starting to notice and getting nervous because they rely on us so much to be there. In July, we did a survey, as we do before each of our committee meetings, asking contractors how things are going, and this was a pretty bleak picture. 70% of pharmacy owners saying they're having serious financial issues and problems financing their businesses, and a large proportion saying that that's impacting on the service that they can provide patients. And we asked them about the top financial pressures, and as you can see from this chart, the key contributing factors was around medicine supply and the instability around that, and also in terms of being able to cope with workforce pressures and inflationary pressures, all impacting on your businesses. And dispensing is a real problem for many people in terms of being able to do it at an economic basis. So what we've seen is this is causing significant problems now, and we're getting these short, sharp shocks, and we're getting a real problem in terms of drug pricing and supply. Our role at CPE is to collect that data from you, from pharmacy owners, to input to the government and say, look, we cannot buy the drugs at the listed prices, and we put forward proposals for concessions. They accept some of those, they impose lower prices, and sometimes they don't accept them at all. So we dispute those, but of course they continue to do that and set the prices. We did do an in-depth review for 6 months with the department to try to improve how the system is working, removing discount deduction from concession products, allowing a roll forward of those late concessions, and a retrospective correction mechanism. But it's not enough because the system is really creaking at the seams. And the reason for that is, of course, that manufacturers are now reluctant to supply the UK because prices of generics are so low. We have those sudden peaks in demand that also create an impact, and also an ongoing growth in prescribing volume. And so basically the margin formula is creaking at the seams to be able to cope with that. And the problem that we have is that those price fluctuations, those pressures, impact the sector very differently. That will depend on dispensing mix, it will purchasing mix, that will depend on what access people have to discounts, what access they have to wholesalers. And that means that there are winners and losers at any time that we're putting forward price concessions. Some people are actually doing perfectly well, and some people are really struggling. And that means that all price concessions then have an impact on the margin that we're allowed to continue to collect. And so when we get over-delivery on margin, that means the prices are squeezed even further, that causes these further shocks. So what it suggests is we're going to have to really look seriously about how margin delivery works. That margin allowance of 800 million has not changed for at least 7 years, and so we've got to look at how well that can work in the future and change it. But there is politically a rising awareness of community pharmacy, and I think that's important because we've actually managed to have a higher impact with our influencing, and we've been able to build many more advocates and ambassadors within Parliament and those who influence decision makers across health and across patients' voice and all of those things. So that basically has lifted the awareness of the challenges being faced by pharmacy and the value of its role. And we've built strong relationships with other players in primary care to make sure they understand and we can put forward a united front on how to improve the primary care system. And we've seen increased coverage in the media in terms of our Save Our Pharmacies campaign. So there's really upped the tempo in public understanding. And the pressures were partially recognised, not sufficiently, of course, last year in our year 4 and 5 negotiations with a write-off of 100 million. But unfortunately, 100 million that you never thought you would have to pay back anyway. So that was not going to go far enough. And of course, just before year 5 began, we also had further negotiations with government where we said, you simply cannot afford the year 5 that you've set out. You have to make some reduction in that, which they did. But the Sunak government, as been mentioned, have been seeking solutions for some really deep and intractable problems that the NHS is facing, and they have seen community pharmacy as being a sector that is offering solutions when there are very few to be found across the NHS. And that means that we've seen some recognition of the value of community pharmacy in the primary care recovery plan. So let's move on to that. So, a reminder of what the primary care recovery plan means. It means that there's a commitment to improve access to primary care by investing up to 645 million over the remainder of this year and next year to support what's called a common condition service. It will be called Pharmacy First. It's a walk-in service which will combine with 111 and with CPCS and other referrals. So it will be a combined service that will be dealing with these 7 conditions that are set out there, from sinusitis to uncomplicated UTI in women. By the way, Scotland, the pharmacies are now doing 80% of uncomplicated UTIs, so that shows the potential there. Alongside that investment, and that's the major part of the recovery plan for community pharmacy, there's also further investment in the contraception service and in the blood pressure check service. And we hope that that money will be able to flow out sooner than the full-on launch of Pharmacy First. And supporting that, and very critical to our future, is a very significant investment in the digital infrastructure to enable community pharmacy to access patient records, to be able to update them and refer back into GPs to tell them what's happened. So that's a really critical part of the plan. And what I would say is, talking to ministers and picking up on their very strong enthusiasm for Pharmacy First, it's been clear that the potential to use PGDs and in future independent prescribers is something they're really interested in that way to make the most of the capacity and competency amongst pharmacy teams to be able to really get them operating at the top of their game so that GPs can then operate at the top of their game. So, you will know that we've been in negotiations since the plan was announced. And those negotiations have now concluded, so we've come to an agreement and it will be announced very shortly. We're just waiting, obviously, when government agrees to new announcements, they've then got to fit it into their governmental grid of announcements, and we've got the King's speech this week, so I think we can expect an announcement within a couple of weeks. Now, the negotiations we've been through have been more complex than usual because of the range of government stakeholders and the really high priority that this programme has had. So it's had to have really high level approval through number 10, through the Treasury, at a level we don't normally do when we're just in our usual annual negotiations. And to support Pharmacy First, there have been some very significant work programmes been going on. So one work stream has been on the clinical pathways, led by NHS England, reporting into the Chief Medical Officer, and that is sorting out the 7 pathways for those common conditions and the PGDs and all of the decision-making moments through that pathway for each condition. So that's been signed off by the Chief Medical Officer, and also the digital development has been led by NHS England with IT providers from both community pharmacy and from GPs. So that's a complex and critical part of delivering this service. And I think for us at CPE, critical to us was trying to get the funding on the right terms to provide you with upfront capacity to respond to patient demand and a fair structure of payments that don't just work now but in the future, because this is clearly a foundation stone for the future. And we've also had to work pretty hard to get an understanding of how the new money coming in was going to relate to the current contract and where activity would be allocated to the current contract, which we know is under pressure, or into the new funds. So that's taken a lot of time to sort out. And of course, there will be still some really significant work to do about how it's marketed to the public and how we continue to actively monitor and manage delivery. We need to understand the volume of activity that's going on and how it can be smoothed over in future. So the detailed announcement will be coming out shortly. We just worked on that last week with the government. So where do we need to get to? Well, these are really difficult times, and we don't underestimate how hard that is to accommodate a new service. Nevertheless, some of this activity is activity you're already doing. So hopefully part of the funding will help to recognise that. And we do need to be able to make the most of this opportunity to demonstrate our value to government and to NHS England, not just for now, but in terms of the future and future commissioning. It's going to be really important that we can show that we can deliver. building pharmacy first, our goal must be that it's recurrent, into the recurrent contract, and a significant addition of funding to the new contract, so that we can have it as a foundation for new investment and growth. And I have to say, having spent a lot of time at all the party conferences, talking to other primary care bodies as well, people have noted that we are one of the few sectors that is getting an additional investment at the moment, given how starved the NHS is. And so that's really important, that we continue to be seen to be having solutions to the pressures on the NHS and for patients. So, now that we've concluded those negotiations, obviously we're going into implementation phase. There'll be a lot of work to be done in terms of supporting materials and tools for all business owners. But at the same time, we need to be thinking about what happens next. And the next thing that will be happening is, of course, the 24-25 negotiations. But just thinking about the future of the contract, what we've been doing for the last year is building all of the foundations for the next contract and changing the shape of how we're commissioned. So we've been building that influencing and profile and understanding of the value of community pharmacy. It's too precious to see it damaged, and it needs to be supported and given an opportunity to be part of the NHS future and to meet the needs of patients. So that influencing is incredibly important. We're of value, we can't be taken for granted. The second has been to make a compelling ask, and that's why we commissioned Nuffield Trust and King's Fund to produce their vision for community pharmacy, because that's the ask. It's not coming from us, it's coming from independent experts, but they're saying the potential for this sector and why it's worth investing in it. Then what we're doing is working on defining that case for investment. Here's the ideas you could support. Now this is the case for investment. So we'll be working with NHS England on an independent economic review of the sector to look at the real cost and value that we can deliver. And we're also doing work on economic and social value, the return on investment that investing in community pharmacy can deliver for public funds. And that needs to be termed in ways that the Treasury understand, comparing it with other asks for investment across a very pressed public spending environment. The next key thing is we are looking at alternative funding mechanisms. The current contract doesn't work. We need to see ways that are fairer to recognise the real costs that we have, and also to understand how the best way is to fund us and incentivise our businesses. So we'll be looking at establishment costs, obviously inflationary pressures, incentives and risk sharing. There are other methods to fund that share risk more equally between the commissioner and the commissioned, and looking at alternatives to caps and margin provision. And finally, we're also looking at promoting the investment that will be needed to be made in our infrastructure in terms of IT and digital, in terms of workforce, facilities, and review of the medicine supply. So, the next contractual framework negotiations, the next contract will be for 24-25, so it's only going to be for 1 year. Why is that? Well, because the spending review has another year to run. So basically, the dead hand of Treasury plans is still in place for another year. So we will be starting on those negotiations straight away. We're waiting for the department and for NHS England to get their mandate, which is what they're approved to be able to spend by government, and we will be starting work on that. And we have already asked business owners and you in pharmacy businesses to give us your thoughts on what we need to input to those negotiations, and we've been working on that. And those include asking, of course, for an uplift to the baseline contract. Simply isn't enough to even do what we're currently doing. A review of fees. They seem to set them and never have any automatic review process. New funding for increased volumes of the existing services that are breaking the bank in terms of over-delivery at the moment, an uplift to allowed margin, and using a lot of the data that we're collecting to support those asks. So that is what we will be doing. But even with this data and the evidence that we can produce in our modelling to support our asks for the CPCF, it is a tough time, as I said, with the spending review, and you can't fail to be depressed when you hear about the pressures on public spending at the moment across both the NHS but more generally. And of course, next year there's some uncertainty introduced by the fact we don't know when a general election will be, but it's very likely to interrupt any plans for the future contract and the next spending review. So that's going to be challenging. And so therefore, we need to think strategically about making sure that we're influencing the shape of future government, whichever government it might be, but their future policy, their future commitments to ensure that we're putting the groundwork in now for future contract. And I think I will skip through this a little bit, but just to say these are the building blocks that I've talked about in terms of seeing us as being valued, rethinking how we're funded and how we can plan as businesses for future sustainability, having a strategic vision about where we would be going, and influencing a shared strategic vision with the department and NHS England. There is no point us having a vision and having a plan if it's not shared with the thinking that NHS England and the Department of Health are doing. And actually recently, we've been briefing in the vision very widely, and we met with Amanda Doyle, who obviously is Director of Primary Care in NHS England, and she said, I love this vision and I really want to be able to talk to you about how we can make this part of primary care strategy for the future. So, the vision. It is key to the future. I think I've made it clear about the building blocks here, so I will skip through because I'm aware of time. But basically, what we're trying to do is have some ambition that shows that this sector can do a whole lot more if it's got the right investment and the right backing from its commissioners. So, we launched with King's Fund and Nuffield Trust their vision for community pharmacy in September, and I think the resounding point that came across was that it's a vote of confidence in community pharmacy in terms of being the true innovators in healthcare and being able to, with the right investment and the right support from government and commissioners, do a whole lot more for patients and communities. And it sets out how community pharmacies can be thriving businesses, building on that essential core role as being dispensers and being a part of medicine supply, but also broadening into a range of clinical services and funded activities that pharmacies can undertake. And it describes how pharmacy teams can maximise the use of their pharmacy teams and using all of the skills there to be able to work more closely as part of integrated healthcare networks. And it suggests a range of actions that should be undertaken. So I think this is really important, the key elements that are in their report. First of all, it's about preventing ill health and supporting well-being. And so those types of elements that community pharmacy has to be a critical part of prevention in terms of helping to support public health campaigns with smoking and weight management, things like that, and also addressing health inequalities and also supporting women's health. To the right, we have providing clinical care for patients. It's clear that there's much more that we could do in terms of moving forwards from just taking blood pressure into thinking about hypertension management in terms of tackling atrial fibrillation, cholesterol management, and all of those elements that make for CVD and being a really major priority in health policy. We could be doing more on respiratory disease and helping people with asthma and around diabetes. So they set out some of those service areas where community pharmacy could do a lot more in terms of helping to support and manage long-term conditions. Living well with medicines, obvious point that we could be doing a lot more on medicine optimisation, dealing with polypharmacy, and working with people who have multiple long-term conditions. And finally, of course, the building block of playing a bigger part in integrated primary care and an offer for neighbourhoods. And so our response has been at CPE to support the direction of travel. We are now going to work to prioritise those key elements of the vision, to work on the plan, to be able to take forward, to influence what NHS England and Department of Health set out as their plans. And we've had a very extensive period of lobbying to talk to all of the political decision makers who we think will be important to be able to commission that future. So obviously we've been talking to the shadow Labour front bench for about 9 months about all of this developing work, and we're meeting with them regularly to update them, to influence manifestos. Of course, we talk to ministers and all of those people around ministers who help influence the future Conservative Party manifesto. And talking to all of those people across health and patient groups and patient voice to get their support for this vision and to promote the role of community pharmacy. And that helps us to build those building blocks for the primary care strategy of the future that will hopefully place more value on community pharmacy as being part of the integrated care system and of primary care. So I'm sorry that's a bit of a gallop through lots of points, but just to say I will take questions during the panel session. I hope that we can give you a lot more information very soon about Pharmacy First, and I hope that we can also start to build a better future for community pharmacy by having more of those allies and that political commitment to the future of community pharmacy as a solution in an NHS that is struggling so hard that with the right investment we could do a lot more. So thank you very much.